Hi guys, welcome back to week 10. This is again is a focused review and summary on the pulmonary and lungs chapter that you were focused on this week. Don't forget, this is in addition to the supplementary lectures that you have from that are already posted with the voiceover. I just wanted to focus in and go over a few key things that I think would be helpful for both your boards and your next exam. So in this particular module, we really focused on an overview of the lung and structure and function, overview of the lung and structure and function in terms of structures of the respiratory system, mechanisms of respiration, and the anatomies of the airways and the alveoli. The chapters definitely got into lung volumes and capacities, as well as lung and chest wall interactions and pleural effusions. It got into a lot of talk about the compliance of the lungs and chest wall in health and disease, including emphysema, decreased lung compliance, and pulmonary fibrosis. It also got into readings about your airway resistance, including forced expiratory maneuvers used to assess airway resistance, concepts of obstructive lung disease, including asthma, COPD, and obstructive sleep apnea, or OSA. And then we got into a lot of talk about gas exchange in the lung, hypoxia and hypoxemia. It talked about pulmonary vascular considerations, pediatric considerations, and gerontological considerations. So keep in mind that the worldwide burden of lung disease when it comes to years in living with disability is about half of that of cardiovascular disease. However, all chronic respiratory disease combined have a higher prevalence than cardiovascular disease. And of course, the biggest contributors to lung disease burden are chronic obstructive pulmonary disease and asthma. A lot of the times this stems from smoking, which we know. Lung disease impairs quality of life and functional status and can result in death. Following an overview of lung structure and function, this chapter describes compliance of the lungs and chest wall, both in health and in disease states, which we will review in this summary as well. Airway resistance, gas exchange, and pulmonary vascular considerations are discussed, as well as issues related to pediatrics and geriatrics, including the geriatric aging lung. So here we go, guys, let's focus. So the first thing I wanted to do was just do a quick video demonstration of the overview of lung structure and function, something quick and easy just to give you a visual review so that you can just review the basic anatomy of what we're talking about here. See if I can get it to play. Just give it one sec, guys. I bet it'll work. Here we go. So here's a quick video just to review the anatomy of the lungs.
Hey everyone, it's Matt from CatHub, and this tutorial features the most well-known feature of the respiratory system, the lungs. The lungs are made of a light and soft elastic tissue. The right lung is larger than the left one and is comprised of 3 lobes, including the superior, middle, and inferior. The left lung only has 2 lobes, which are the superior and inferior. Fissures help separate the lobes, and each lung has an oblique fissure, which divides the upper and lower lobes of the left lung and the middle and lower lobes of the right lung. The right lung also has a horizontal fissure, which separates the superior and middle lobes. Each lung also has 3 surfaces: the costal, the mediastinal, and the diaphragmatic, which are named after the adjacent anatomical structure which that surface faces. The mediastinal surface connects the lungs to the mediastinum via its root. The root of the lung contains the mainstem or lobar bronchi, the pulmonary vessels and bronchi, as well as the bronchial vessels, lymphatics, and autonomic nerves. The respiratory airways and the lungs are lined with respiratory epithelium. Let's review the path of respiration for clarification. Once the air enters the larynx, it is purely within the respiratory organs. It continues down the larynx and into the trachea, which bifurcates into the left and right main bronchi, and then further in a tree branch-like pattern into bronchioles. The bronchioles further divide into smaller and smaller respiratory bronchioles, whose terminal branches contain grape-like bunches of alveolar ducts, sacs, and the terminal alveoli. It is here that the oxygen in the air cells diffuses into the blood. The opposite occurs for the carbon dioxide when it attempts to leave the hemoglobin molecules in the erythrocytes and travel back out of the body via exhalation. This video is more fun than reading a textbook, right? If you want more videos, interactive quizzes, articles, and an app.
So hopefully this was helpful in just reviewing the lung structure. I love these Ken Hub videos. They're very, very beautiful visual demonstration of anatomy and physiology. Okay, so again, overview of lung structure and function. Here is just your basic diagram of your anatomy of your respiratory structures. Remember our left lung, right lung, ribs, just know your landmarks, okay? And in terms of lung volume versus lung capacity, just make sure you're able to differentiate the two, all right? You know, the values are directly measured by a spirometer. And keep in mind, lung volume values are usually small versus lung capacity values are large. Things that you want to make sure too is that you really understand the mechanisms of respiration. Okay, you want to be able to describe the basic mechanisms of rhythmic respirations. Like what is the role of the brain in generating regular inspirations? And what is the general mechanism of expiration during normal quiet breathing at rest? These are things you just want to make sure that you can differentiate. The other big thing I wanted to just point out is that the lung and chest wall properties and neuromuscular strength of respiratory muscles determine the capacity for airflow and the volume inspired and expired. So when you do your pulmonary function testing, they report these volumes and capacities as part of your lung assessment. All right, and keep in mind, the lungs are highly compliant. They're easily expanded during inspiration and recoiling during expiration. With appropriate volume changes driven by relatively very small pressure gradients. So it doesn't take much for the numbers to change. Okay, compliance of the lungs and chest wall in health and disease. So keep in mind, you want to know surfactant and lung compliance, what emphysema is, the diseases of decreased lung compliance, idiopathic pulmonary fibrosis, and the concept of chest wall compliance. Okay, so there's that concept that the pathophysiological loss of lung compliance limits the lung's ability to expand, which requires extra effort to inflate the lungs and then therefore decreases the measured lung volumes. This is characteristic of acute surfactant deficiency or chronic fibrotic or infiltrative lesions of lung tissue. So here in this diagram, it shows you during inhalation, we are active and our muscles contract versus exhalation is passive and the muscles relax. So in emphysema, for instance, there's a breakdown of lung elastin and other connective tissue fibers, which increases the lungs compliance and enlarges the lung air spaces, causing a hampering in the gas exchange. Inflation of the lungs is very easy, but elastic recoil is poor and emptying the lungs becomes very difficult. And therefore in emphysema, the air trapping then enlarges the lung volumes, leading to your barrel chest, right? As we know in our emphysema patients. The airways are relatively low resistant passageways and only small pressure changes are needed to move air in and out with normal quiet breathing. The main measure of airway function is the volume of air exhaled in the first second of a maximal expiratory effort, also called a forced expiratory maneuver. The forced expiratory volume is 1 second, so it's FEV1, and it stresses the airways by surrounding them with positive pleural pressure. This tends to collapse the airways as the lung volume decreases. And remember, disorders of airway resistance are known as obstructive diseases. Okay. So airway resistance, all right. Airway smooth muscle is controlled by the autonomic nervous system with sympathetic stimulation causing bronchodilation via the V adrenergic receptors, and parasympathetic stimulation causing bronchoconstriction via muscarinic receptors. And asthma is your principal acute obstructive disorder. It has airway narrowing after antigen exposure. So just keep that in mind. And then let's talk about a measurement of airway resistance or a measurement of respiratory resistance. So as the flow is recorded, the air pressure decreases and the box pressure increases. All right, I just wanted to do a quick video review of this as well. I just felt like understanding the concept of airway resistance is sometimes easier from a visual guide. So let's just watch this quick video. Again, less than 5 minutes, just to give you a quick
Airway
overview.
resistance is a term that refers to the measurement of impedance to the movement of air through the respiratory tract during the breathing cycle. We created this video to cover the medical definition and provide a brief overview of this topic. So if you're ready, let's get into it. As previously mentioned, airway resistance refers to the amount of resistance to the flow of air through the airways of the lungs during inspiration and expiration. Physiologically speaking, in the trachea, airway resistance is responsible for turbulent airflow. In the bronchi and bronchioles, is responsible for laminar airflow, in which the air flows more smoothly towards the alveoli so that gas exchange can occur. If a patient has an increased airway resistance, this can result in air trapping, which limits gas exchange and can lead to respiratory failure in severe cases. A common example of this is seen in patients with COPD. The biggest factor of airway resistance is the diameter of the airway. If the diameter increases, this means that the airways have opened up, which results in less airway resistance. However, if the diameter decreases, it means that the airways are constricted, which results in more airway resistance. As previously mentioned, asthma is an obstructive lung condition that causes increased airway resistance due to chronic inflammation of the conducting airways. During an acute exacerbation of asthma, as the airways become more narrowed, the patient will show signs of dyspnea, wheezing, chest tightness, and air trapping in the distal segments of the lungs. In such a case, certain medications may be administered to reduce airway resistance and open up the airways. Some examples include albuterol or other short-acting beta-2 agonists, ipratropium or other anticholinergic agents, and inhaled corticosteroids, which typically help to prevent episodes from occurring. Again, for this video, we just wanted to provide you with a brief overview of this topic. We'll be breaking it down into much more detail in a separate video. Real quick, guys, do me a huge favor and hit the like button. It really helps support the channel, and I greatly appreciate it.
So if you wanted to
And while you're
get
down there,
more
go ahead and click the
information and get better videos for further clarification on these subjects, you could go to their respiratory therapy zone is the name of their page, but they offer great visual guidance with respiratory stuff. So it makes it a lot easier to understand it and retain those visual images to help you remember what you need to remember, both for your boards and your clinical practice. Okay, so in terms of gas exchange in the lung, couple of things you need to make sure you're able to describe the alveolar capillary interface and the role it plays in the uptake of oxygen and onto hemoglobin for the delivery to the body. So here's a beautiful little diagram with gas exchange at the alveoli and a diagram showing how it flows. Okay. And then here, the other big thing I want to make sure that you can identify mechanisms of hypoxemia or low oxygen pressure in arterial blood. All right, there's like 4 different ones. You need to know all of them. Okay, so pulmonary vascular considerations. Keep in mind, the lung vasculature is a richly branched bed that accommodates the entire cardiac output of the right heart, surrounding each of the millions of alveoli with blood flow for oxygenation and CO2 removal. Regional lung blood flow is sensitive to local PO2, with hypoxia leading to vasoconstriction and to gravity, with the greatest flow going to the dependent lung regions. Pulmonary vascular pressures are substantially lower than systemic vascular pressures, and the right heart has a thinner wall consistent with its lighter workload. Increased pulmonary vascular pressures can result from heart failure, leading to pulmonary congestion and ultimately pulmonary edema. On the other hand, increased pulmonary vasoconstriction due to hypoxic lung disease can cause secondary heart failure. So here in this algorithm, it just shows you different presentations for each thing in terms of pulmonary artery, congenital versus acquired, pulmonary veins, congenital versus acquired, and other pulmonary vascular abnormalities, also including bronchial vasculature. Okay, so pediatric concerns that I wanted to just point out. The one thing I wanted to point out is just keep in mind that asthma often begins in childhood and can have greater airflow limitations due to the smaller airways in children. All right. And things that I wanted to point out to you in terms of being conscious of in pediatrics, they have an immature nervous system, which automatically predisposes them to hypoxia. So things that you're going to see in children, hypoxia can cause bradycardia. Bradycardia causes hypotension, and bradycardia worsens hypoxia, especially in babies. Scared children cry, which leads to increased secretions, increased airway irritability, increased risk for laryngospasms, increased risk for wheezing, and increased for airway edema. Children who become uncooperative cannot follow instructions. They struggle and fight, which causes an increase in stress and metabolic rate. All right. So again, this will also lead to more hypoxemia. Children who are easily sedated because they have immature neurons, less myelinization, weak blood-brain barrier, little prior exposure to drugs, and an increased risk for respiratory depression. Apnea of prematurity, the more premature the baby, the greater the risk. They always will have altered ventilatory responses to hypoxia, hypercarbia, sleep, and things can be made worse if the infant is stressed, cold, or ill. Apnea leads to hypoxia, which leads to bradycardia, which leads to worsening hypoxia. All right. And then in terms of geriatric considerations, you need to be able to know the differentials between a young lung versus an aging lung versus an old lung. Okay, so older adults have normal age-related reductions in compliance, resistance, alveolar recoil, and chest wall compliance. Those factors combined with increased risk for aspiration and decreased mucociliary clearance and cough efficacy predisposes your geriatrics to a greater risk of pneumonia, specifically aspiration pneumonia, which I'm sure many of us have seen, and a greater pneumonia-associated morbidity and mortality. Okay. Again, here's just some more great diagram that showed, overall physiological aging changes. Specifically, I wanted to point out, obviously, the respiratory in terms of aging. Your respiratory changes that occur are you have a decreased tidal volume, a drop in vital capacity, an increase in residual volume, a decrease in your lung capacity, a decrease in compliance, and a decrease in response to hypoxemia and hypercapnia. Keep in mind that the larger the chest circumference contributes to air trapping, which flattens the diaphragm and causes greater difficulty with expiring the inspired volume. So that really affects, obviously, your lung compliance. Okay, these are things that happen as we age. Air compliance, flow resistance, it's much lower as we start to grow older. And those are the big points that I wanted to just make sure I've reviewed. Other key points that I wanted to point out are that you're making sure that you're understanding lung capacity and lung volumes, how they're being measured, and what the differences are between tidal volume, residual volume, vital capacity, and total lung capacity, okay? Understand the causes of decreased lung compliance as it is in asthma. Know the risk factors specifically for obstructive sleep apnea, also known as OSA. That's very important because a lot of your patients specifically who are obese or overweight, if they come in with any of the symptoms of OSA, you're going to want to rule that out as a diagnosis. You want to know the risk factors for pulmonary emboli. That's a big one. And you also want to make sure to understand the damage that smoking causes to the lung cells. Okay, very, very important. Because the importance of really understanding that is also very important in order to educate your patients on, why smoking should really be encouraged to be stopped with your patients. So I hope this will help, guys. Again, this is just a focus summary. Definitely use your other PowerPoints that are already uploaded into the module. Use this as a guide to just really know what to focus on specifically for your boards and your exams. All right, I hope this is helpful. Have a great week, and I will see you next week. Thanks, guys.